When CAD progresses, it can lead to continued coronary ischemia. And if coronary ischemia does not get resolved, eventually that can lead to cell damage or death. That leads us to myocardial infarction. So when ischemia continues and it does not get resolved and we don't resume the perfusion or circulation in the coronary arteries, that can lead to myocardial infarction, such as the illustration here. So if you can see, there's a blockage in the vessel, and this leads to irreversible cell death or damage. So this cannot be undone. What are the signs and symptoms of myocardial infarction? So myocardial infarction can cause intractable chest pain. So intractable meaning chest pain that does not go away. So it's not relieved by rest, oxygen, morphine, nitrates, etc. Basically, after administering MONA, morphine, oxygen, nitrates, aspirin, and the patient continues to have chest pain, then that's a huge indication of myocardial infarction. Patients describe the chest pain that they experience a little different. Sometimes the location also varies, but again, such as the unstable angina, a very common description of the pain is pressure, crushing chest pain. A common one that we've been hearing a lot too is, it feels like there's an elephant sitting on my chest. So when a patient says that, there's a huge likelihood that the patient is having an MI or myocardial infarction. So on assessment, it's not always consistent. So it doesn't mean that these are all the signs and symptoms, or these are all going to be your assessment findings for patients having a myocardial infarction. So these are possible, but it doesn't mean that it always happens. Sometimes there are changes in vital signs, elevated blood pressure, sometimes decreased blood pressure, heart tones change, and also cardiac rhythm changes. So you can see some dysrhythmias, and definitely you can also see ST elevation on a 12-lead EKG. Occasionally, you can also assess for pulmonary crackles, dyspnea, fatigue, diaphoresis, nausea, and vomiting. When it comes to labs, we take note of the cardiac enzymes of the patient. So a lot of the times, patient will show increase in their cardiac enzymes such as the troponin. Myocardial infarction or MI can lead to the following complications. So these are not inclusive, meaning there are other complications that can happen from MI, but these are some of them. So dysrhythmia, so disturbance in the cardiac rhythm or electrical activity of the heart. Sometimes patients develop pericarditis or the inflammation in the pericardial lining of the heart. MI can also lead to heart failure, and ultimately it can also lead to cardiogenic shock. Cardiogenic shock is when the heart loses the ability to pump blood effectively, causing the patient to have decreased cardiac output or decreased blood pressure. In general, when patients are experiencing MI or myocardial infarction or heart attack, nurses will provide oxygen. So we provide oxygen. Again, we do the MONA. We try to control the electrolytes, especially the K and MAG, because this will help prevent dysrhythmias. Because as we discussed earlier, MI can cause patients to have cardiac dysrhythmias. Also, general treatment would include controlling dysrhythmias. So if a patient develops a new onset of cardiac dysrhythmia, then we need to make sure that we control that. And lastly, patient education. Again, patient education, it needs to be timed. We need to talk about the disease, the treatment, and also psychosocial support. And when patients hear heart attack or MI, there's a lot of fear. So we also need to consider, is it a good time to actually teach the patient about their condition? Are they going to be receptive? And again, there's appropriate time for that. Priority is really provide the other interventions and hopefully try to find some time for some education. And definitely another important thing is after discharge, the importance of following up with their providers, because that will prevent a subsequent or a recurring event of a heart attack. So how do we treat MI? So these are the pharmacological treatments for MI. One, we want to treat the acute pain. So acute pain management with morphine, right? So that's the medication of choice. Next, we also want to make sure that we administer vasodilators or nitrates. As mentioned earlier, there are short-acting nitrates, which includes the nitrostat or nitroglycerin sublingual tablets. There are the long-acting ones, which is Imdur or isosorbide mononitrate. We have topical, there's a patch, which is Nitrodur, and Nitrobid is the ointment version of the nitrate. And sometimes, when indicated, we also administer IV nitroglycerin. Another pharmacological treatment component for MI is platelet aggregation inhibitors or antiplatelet agents. These are the examples. So what are the examples of platelet aggregation inhibitors? So one, aspirin, and another very good one that we use is clopidogrel or Plavix. In addition, we also use beta blockers. So why do we use beta blockers? Beta blockers decrease the myocardial oxygen demand, thus decreasing the heart rate, the blood pressure, and improving the contractility. This improves outcomes of MI patients. What are the examples of beta blockers? Atenolol, metoprolol, and propranolol are examples of beta blockers used in MI. In addition, we also use calcium channel blockers. Similar to beta blockers, calcium channel blockers decrease the myocardial oxygen demand. It does decrease the heart rate, blood pressure, and it helps with contractility. In addition, it also causes smooth muscle relaxation. So that helps with the workload of the heart. Examples of calcium channel blockers that we used are Norvasc or amlodipine, cardizem or diltiazem. In addition, a very important component of the treatment for myocardial infarction are anticoagulants. So on the next recording, we're going to talk more about anticoagulants.